I want to welcome Dr. Leanne Williams to the stage. She's a professor in the Department of Psychiatry and Behavioral Sciences and founder of the Stanford PanLab for Precision Psychiatry and Translational Neuroscience. Prior to coming to Stanford, she was the founding chair of Cognitive and Neuropsychiatry and directed the Brain Dynamics Center at the Sydney Medical School. And she's going to speak with us about envisioning the BrainMind clinical lab of the future. Welcome to Lee.
Thank you very much for the introduction. I'm delighted to be here. My message today will be about it's time. And that is, it's time to radically transform our brain-mind understanding of mental health. And you've heard some of the background context to that from other speakers, which I will draw on as well. The radical shift is going to require us to think in an integrative way, to bring together concepts that have been fragmented. We see that in multiple levels. We see it in fragmentation of how we even think about brain and mind being separate. And you'll see in the theme of this summit, they're actually fused in the title. And I think that's really important. I'm excited to share one way in which we are making a radical change. And that is to think about precision mental health informed by neuroscience and thinking about it in terms of how can we accelerate its translation into the real world. The way that I will unpack for you that we're thinking about it is, first of all, deal with the fragmentation on multiple levels. So the first one is how do we integrate data and how do we do it in terms of humans, taking into account the bottom-up insights that you've heard so much about, but also thinking of it as top-down, thinking what are the needs that we have from a human top-down level to translate the insights. The data I'll share with you is mostly from functional MRI in humans, but is fused with data from EEG, genetics, and increasingly from wearables. The next phase is to go beyond our current traditional diagnostic categories and to think about a way to innovate in classification, and that is taking these data as the anchor. The next piece is, if you're thinking about scaling, as Tom Insel highlighted, we need to think beyond the lab. So how do we take the brain into the real world? My belief is that in psychiatry, we don't yet have the models to do that in a way that we can interpret them, so I will touch on that as well. And of course, for this to be interpretable and meaningful for humans, we have to know that we have targeted interventions and we have ways to actually prevent the illnesses that we're focusing on. So ideally, we're actually doing this accelerated translation in a closed-loop system. I'm going to focus on mood disorders, and that's the focus of my research, although these numbers are unfortunately true and relevant to multiple serious mental illnesses. In my lab and our work, we focus in particular on depression, but mood disorders more broadly, and that is recognizing the incredible and staggering need. So we know number one cause of disability is depression. $1 trillion globally is lost in the global economy due to lost talent, lost productivity. Globally, we have 405 million people impacted by depression, and everyone in this room will know that's the case. And now our numbers are increasing, unfortunately. So 1 trillion suicides per year worldwide, and that translates to 1 every 40 seconds. So this incredible impact, we obviously need to do something about it. We would if it was another epidemic. And importantly, I think, as well as that social and global need, there's also economic, or recognition of the economic need. And the fact that dealing with this, addressing this need, will also have an economic impact as well. And increasingly, such as in this article in the Financial Times, the point about we are ready to actually apply precision medicine to mental health is being recognised. What is our current situation? So right now, as many of you would know, either personally or through your loved ones, if you're experiencing a mood disorder, you do not know which intervention is likely to work the first time that you're considering it. It's usually not clear where to go or what kind of health provider to go to. And this is despite the incredible expertise and compassion of the providers and the commitment of the field. So you could consider multiple different possible interventions, but not know what is suited to you as an individual. And as an individual, you each have incredibly different brains. They're shaped by your own experience, they're shaped by your genetics, each one of them miraculously different. We're not trying to reduce each person to something that is just their biology. It's recognizing that individual nature of you. So it is time to change this situation. Because of the incredible advances that you're hearing about at this summit, we actually have the opportunity to make the change. And I'm excited to share with you some ways in which we're doing that. And it is by recognizing each individual person's brain type or brain profile. Inspiration comes from other areas that are complex and stigmatized, and yet breakthroughs have been possible, and they're possible in our lifetimes. So by a concerted integrative effort, we could imagine making the kind of leaps forward that have been made, for example, in cardiac medicine. So 1948 is not that long ago. But at the time, FDR, they didn't know how to treat his heart problem at the time, unknown, wrong treatment, and he unfortunately died. It initiated the Framingham study, which subsequently has led to so many breakthroughs. 1958, first breakthrough that has led to precision medicine for cancer, discovery of the estrogen receptor. More recently, 2002, so HIV is like one of the most stigmatized complex conditions that we can think of in our recent lifetimes. And yet, discovery of a molecular marker identifying people with hypersensitivity to the ABC treatment has dramatically transformed how we understand and an opportunity to destigmatize HIV. So now, with the insights we have from neuroscience and in the brain, it's a chance to do this for mental health. And my case would be that mood disorders are a tractable place to start and one that could make a difference globally. So the approach we can think of would look like these other complex disorders. So if we think of cancer medicine, by imaging the tumor, the issue that is at the core of the illness, we can identify subtypes. And right now we would think it odd if that didn't happen. If you went to your oncologist and they said, I'm going to ask you a few questions, I'm going to rely on your self-report, and I'm then going to choose your treatment, you would not accept that. And we have, thanks to a fairly recent set of insights, the capacity now to image the tumor, take your genetics, and guide the treatment choice. Similarly for cardiac medicine, as I've mentioned. Again, it doesn't reduce people to just their biology. In cardiac medicine, by having images of the heart, by taking account of your individual experience and lifestyle choices, there are multiple possible interventions that could be considered for you. And they could range from lifestyle to drug to surgery to all sorts of different techniques being developed. So that's what we envision here. The focus needs to be, I would argue, on the organ of interest, and we're hearing a lot about that as we go through these 2 days. I've a focus for now on 6 circuits of the human brain. These are ones that have been fairly well articulated in the last decade, and that's thanks to big initiatives, actually some inspired by Tom Insel, such as the Human Brain Connectome Project with NIH funding. and multiple input and contributions from imaging researchers. So these 6, I think, are interesting for mental health because they involve, as I think of it, fairly recently evolved circuits of the brain. Some you can see homologies in animal work, animal models that are fairly conserved, but they do involve human functions. So one is the default mode network that you may have come across in reading. It's very relevant to our concept to actually reflect on our internal states and thoughts. And that is something that appears to be very relevant to the intrinsic way that our brain's organized and anti-correlated when we focus our attention or regulate our emotion. We have the salient circuit, the green one, which is relevant to how we perceive our introceptive and extraceptive, like salient experiences, including pain and emotion, salient cues in the environment. It helps us engage our attention. One called the threat circuit or negative affect, negative emotion, which is relevant to how we respond to potential threats and sources of potential danger. We see this circuit disrupted when we have traumatic experiences. One known as positive affect or reward, which you will hear more about, no doubt, in the next session, which is relevant to our motivated behavior and how we respond to positive emotion, our feeling of being able to feel good and want to do things. We have one known as the attention circuit, which is how we actually sustain our attention, how we attend to relevant information. And we have one for cognitive control, sometimes called the central executive, which subserves the functions that Ruth O'Hara outlined so carefully. And these circuits I focused on because dysfunctions in these circuits are observed in multiple types of depression and anxiety and other mood disorders. So they're a tractable way to develop new subtypes. And I refer to these as biotypes. So different ways that these circuits get disrupted can cause different kinds of experiences that we see, for example, in depression. So one would be biotype 1, that blue default mode circuit. If that becomes too connected, that is the time when you will have too much internal reflection. So you may have experiences such as rumination, worrying, waking up early in the morning and unable to stop your thoughts about what terrible things might happen. A dysfunction in the purple circuit for reward, type 4, that's when we will see a loss of the ability to experience pleasure, difficulty engaging in motivated behavior, and just a feeling of incredible flatness, even if there's a capacity to function cognitively. So how do we go about defining these subtypes using measurement differently to how we currently diagnose? Obviously, we need reproducible metrics to do this, and that's been one of the areas of focus for my lab. So we have the circuit dysfunctions, we take our current knowledge to define those, which is the top row that you can see. And what we've developed is a system for quantifying those circuit dysfunctions in a way that we can reproduce and apply in each new study or each new patient. So in the second row, we take measures of the amount of activation in those regions and the connection strength between them, and we convert them into formula. So we can extract from an image the data that are quantifiable in amounts of activation and connection, and then convert them into numbers. And that gives us a way to accelerate the speed at which we can do this and ultimately diagnose. Of course, if these metrics, they can be reproducible, but they won't necessarily be useful if they don't give us actionable information. Can they tell us about treatment? Can they tell us about prevention? I'll show you a couple of snapshots in the last few seconds on the findings we have. These are cross-validated in our current studies with an accuracy of 75 to 81%, which is moving the needle from our current treatment accuracy. So that default mode tells us about whether or not you're likely to remit on typically prescribed antidepressants, and alternatively, if you're likely to respond to TMS. The reward one, we're finding exciting new insights to see that dysfunctions in that circuit, those individuals do not respond to standard antidepressants, but will respond to selective dopamine agents. When we look at the attention circuit, we see response only on very particular antidepressants, not common antidepressants, and exciting insights that there may be a response to psychostimulants, some of which are used to treat ADHD. So this has been possible, this work, because of my lab, currently about 30 people, and expanding to collaborators across the campus and nationally. I want to share with you our vision for where to take this. And this is an initiative that's been launched recently with a home in psychiatry with the facilitation of Laura Roberts, our chair, the Centre for Precision Mental Health and Wellness. And what we're envisioning is this closed loop opportunity, like how do we bring these measures, people, interventions, and discovery together in the one space and deal with the fragmentation. We need, of course, to increase the definition of the imaging. So our new studies, we have a Connectome project for depression and anxiety. One of my collaborators, Ian Gottlieb, is here, and we're using high definition imaging to increase the precision of these subtypes. We're also expanding the intervention menu, and that is to move to fast-acting interventions like ketamine, which we hypothesize will help with the default mode dysfunction, looking at novel interventions that are being developed in more discovery work. A project with Rob Malenko, we're looking at dopamine targeting agents. We have a project looking at behavioural interventions, and in that case, that's the one where we include the MindStrong app as well, as a goal of how do we scale this information. Of course, it's important to expand and consider not only dysfunction, but how do we consider optimal function, and ideally, we can use the same targets and subtypes for prevention. In order to do that, we need to do two things to achieve speed and scale. One is how do we rapidly deploy this kind of subtyping, and we think of this in stages, going from high throughput data processing systems right through to the end of being able to deliver a report. And the report, this is how we currently imagine it might look. So you could imagine looking at a screen and you would get what is your profile, your biotype, how much of that dysfunction or function do you have, what's your profile look like, and in the top right, how does that relate to your experienced symptoms and coping strategies? So it gives you a more holistic picture. We could imagine using this for interactive discussions and formulating the experience of mental health differently. We could also imagine scaling it. So how do we take this brain information and deliver it on the smartphone, as Tom Insel highlighted? And how, again, do we use that in an interactive way? So we are increasingly relying on not only the technology, but the precision insights of the mental health professionals. So the last point I wanted to bring, getting back to its time, in order to make this happen, I think we need something like a Framingham study for mental health. I envision a Bay Area cohort study where we can gather this information in large cohorts over time, imaged EEGs, interventions, wearables, smartphones, everything together. And I look forward to working with all of you on making that happen. Thank you.